Hi, my name is Blake Burrows, and I am a PGY3 anesthesiology resident. Today, I will be presenting our quality improvement project titled Safe Passage Implementation of a Standardized Cardiac Transport Monitoring Protocol to Eliminate Data Gaps. Transport of cardiac surgical patients from the operating room to the intensive care unit represents a high risk transition of care. These patients frequently have invasive monitoring, vasoactive infusion, fresh surgical sites, and limited physiological reserve. Even brief periods of hemodynamic instability during transport can be clinically significant. Prior to this intervention, transport of post cardiac surgical patients relied on standalone portable monitors that were not integrated with the electronic medical record. This resulted in a complete gap in physiological data between departure from the operating room and arrival to the ICU. If patients experienced hypotension, arrhythmias, oxygen desaturation, or other transport related events, there is no objective record available in the EMR. Documentation often depended on provider recall or verbal handoff communication. Additionally, arrival to the ICU created a workflow challenge. The care team was required to disconnect the patient from the transport monitor and reconnect all the monitoring equipment to the permanent ICU monitor. This created unnecessary complexity during a high acuity handoff, when the focus should instead be on patient stabilization, communication, and safe transition of care. The aim of this project was to increase the percentage of cardiac ICU transports utilizing continuous EMR integrated physiological monitoring from 0% to standardized implementation by May of 2026. To address the issue, we implemented an ICU integrated portable transport monitoring workflow and standardized the process for cardiac surgical patients requiring ICU transfer. Before transport, the ICU nurse prepares the ICU compatible portable monitor, enters the patient information, and sends the ICU bed with the transport monitor to the operating room. Prior to leaving the operating room, the patient is connected directly to this ICU integrated monitor. Continuous physiological monitoring is maintained throughout the transport to the ICU. Once the patient arrives, the portable monitor seamlessly docks into the permanent ICU monitor, allowing automatic continuity of monitoring and immediate EMR integration without requiring a manual monitor transition or cable exchange. Following implementation, cardiac ICU transports transitioned to the standardized workflow using integrated transport monitoring. Continuous physiological monitoring was maintained from operating room through the ICU arrival, eliminating prior gaps. The workflow also removed the need for manual monitor and cable transition during ICU arrival, reducing disruption during handoff and improving overall efficiency. Importantly, transport related events are now objectively documented and reviewable within the EMR. Using a plan, do, study, act framework, we first identified the absence of continuous physiological monitoring and EMR documentation during our transport. We then implemented the ICU integrated transport monitoring workflow for cardiac surgical patients. We studied the intervention through observation of improved monitoring continuity, elimination of data gaps, and reduction in workflow disruption during ICU handoff. Finally, we acted by standardizing the protocol across cardiac ICU transports with plans for expansion to additional ICU bound surgical patients. The key impact of this project was elimination of transport related data gaps during the vulnerable period of care. The interventions simplified the high acuity workflow, improved situational awareness for care team, and enhanced patient safety during transport. This project also reinforced several important lessons. First, standardized workflow reduce cognitive burden during complex patient transitions. Second, integration of monitoring systems improve reliability and accessibility of physiological data. And finally, the multidisciplinary collaboration between anesthesia, ICU nursing, perfusion, and surgical team was essential for the successful implementation and sustained adoption. There are limitations to this project. It represents a single center quality improvement initiative and was initially limited to cardiac surgical patients. Additionally, direct clinical outcomes such as complications or mortality were not formally measured, and success depends on continued staff compliance with standardized workflow. Next steps include expanding this protocol to additional ICU-bound surgical patients, uh, evaluating transport-related adverse events, and patient outcomes, incorporating the process into institutional transport policy, and utilizing EMR-based analytics for continued quality monitoring. In conclusion, implementation of the standardized ICU integrated transport monitoring protocol eliminated physiological data gaps during cardiac ICU transport, simplified the workflow during high-risk transition of care, and improved patient safety through continuous EMR integrated monitoring. Thank you.